This is brought to you from awesomereview.com. Let's do a acid-base question. A patient with tinnitus, lethargy, and tachycardia. Sodium is 140, potassium is 4.9, chloride is 100, bicarb is 16, pH is 7.48, PCO2 is 21, bicarb is 16. This patient most likely has what? Well, in any acid-base question, the first thing you'd look at is the pH of the ABJ. And the pH of the ABJ here shows it is alkalosis. And what kind of alkalosis is this? Looking at the PCO2 of 21, you call it as respiratory alkalosis. All right, this part we are clear. There is no doubt this is a predominant disorder. Now, anytime you do an ABG scenario, once you look at the primary disorder, the second step would always be calculating the compensation. The compensation here depends on looking at the PCO2. So the normal PCO2 in us is 40. The normal bicarb in us is 24. So the PCO2 drops from 40 to 30. The kidney says, why do I need so much bicarb? Let me dump some bicarb. There's not enough acid. So therefore, it'll dump some bicarb. So it is for every 10 decrease in PCO2, then the bicarb decreases by 2. So it'll be 22 now. So if the PCO2 is 30, the bicarb is going to be 22. If the PCO2 were to be 20, then the kidney is going to dump another 2 millicurrents of bicarb. So it will be 20. So if the PCO2 is 20, the bicarb should be 20. So this 20 would be adequate compensation. However, here we have a bicarb of 16. Why is it 16? Why is it -4? Because this -4 represents additional acidosis. So this patient has not only respiratory alkalosis, but also a additional acidosis as well. So with compensation mechanism, we recognize the patient has acidosis. So where do you see a respiratory alkalosis along with a concomitant acidosis? Not just compensated acidosis, but a concomitant acidosis. So this is a common thing. Millions of people are taking aspirin in the United States, and they watch ads which show that bare aspirin is good for heart and good for pain. So some elderly people take a bunch of aspirin when they have pain or whatever the case may be. They took a bunch of aspirin, and the first thing that aspirin does, it will cause respiratory alkalosis. That's something you need to know. Then the patient is taken to the ER, and then the acidic component has kicked in as well, and there is acidosis. Now the thing that is going wrong in the ER apparently would be a physician would look at the pH of the ABG and say, oh, this is alkalosis, and say, oh, PCO is 21, oh, that's respiratory alkalosis. Okay. And a medical student is asking, doc, but why is the bicarb 16? And the physician is like, yeah, that's because, when there is respiratory alkalosis, then there's a metabolic acidosis. And what they missed was the compensation mechanism here. If they had checked the compensation, then if they saw the bicarb was even lower than what it should be, then they would have recognized there is additional acidosis going on, and this could be a aspirin toxicity. Usually this is sometimes missed, and people think this is, oh yeah, he's tachypneic, he's elderly, he's got respiratory alkalosis, all right, let's send him for CT angiogram for rule out PE. What will CT angiogram show? Nothing. And that's a wasted test, wasted healthcare expenditure, and you don't even know the diagnosis. Now, if you were to do the compensation and uncover the acidosis, you recognize this as clearly a patient who has acute aspirin toxicity. Now, if you knew it was acute aspirin toxicity, then you'd be looking further for, okay, if this patient has aspirin toxicity, then you want to classify them depending on their symptoms and the aspirin level. So if the aspirin level is less than 600, then you say, oh, okay, so basically conservative measures, so maybe fluids, hydration is what you should be doing. If the patient has a level between 600 to 800 milligrams, and the patient has increased respiratory rate, tachypnea, then you want to alkalinize the urine. Alkalinize the urine. If it is more than 800 and the patient has mental status changes, then you'll be doing all the above plus hemodialysis. So the practical implication is you do all these things, the fluids and the alkalization of urine and or hemodialysis, if you knew it was aspirin toxicity. And you would know it is aspirin toxicity if you calculate compensation and uncovered this additional acidosis which is existing with respiratory alkalosis. A lot of physicians, when they look at the pH of 7.48, they think it is only alkalosis and there's nothing else going on. If only there is compensation, you can recognize that additional acidosis going on. Therefore, this is going to be a very important scenario for you to know. Thank you for watching. So this was brought to you by Habeeb Rahman, awesome review of internal medicine, tutormd.com. Look out for more videos.